Good afternoon. I guess it's afternoon now. I would like to thank Professor Palwan to invite me here. I'm kind of new to the wireless technology, so I'm originally from Kenya, and if you get a chance to visit to Kenya, it's a beautiful island called Lamu. So what I'm going to address today is the problem that we are having in the 3D localization of the dental occlusal plane in natural head position. And the way to start that is to go back and look at the history. So around 1931, CEPHALOMETRICS was introduced in orthodontics with the advent of the lateral head X-ray. And the applications were for diagnosis and treatment planning, growth assessment, prediction, and evaluating treatment changes. So the challenges of cephalometrics were finding stable points on the lateral head X-ray and reproducing those points over time to allow comparison. So this is the original cephalostat that was used. As you can see, there are attempts to stabilize the head in 2D dimension. So you have an X-ray source that goes, I'm looking for my laser pointer. That's okay, I have one. Okay, so there's an X-ray source, and that's the film. So there's been an attempt to put the head in a rigid position. So these are all the different cephalostats that were introduced. So that's the lateral head X-ray. Once that X-ray was taken, the orthodontist got busy planning different angles and planes to study the malocclusion, the skeletal deformities, dental deformities. And these are all the different planes that we can look at in different dimensions. So, once this was developed, how do we standardize this? And there are different planes. Remember, now we are only looking at things in 2D dimension. So one of the planes that was suggested very early in the 30s was the Frankfurt plane. It's actually from the orbit to the tragus. And unfortunately, that changes quite a bit. The second that was suggested was the Sella-Nasion plane. And this one is pretty stable because the cranial base finishes growth at 7. And what they figured out was that if you draw a horizontal at 9 degrees, that would standardize your angles. But what happened also with this was that sometimes the Nasion point here would be higher or lower, and the degrees could be much higher. So another standardization technique was developed in the 40s called the natural head position. That's what I'm talking about. It's actually based on the true vertical. All of us have a natural position. If you look at a blind person, sometimes they look up or they look down. But most people have this confident position, which is based on the true vertical. It's the rested position, parallel to the floor. Usually the eye is at level to the person looking straight ahead. It's a self-balanced position, and it can be guided by a mirror or by a professional, and it's usually reproducible. But, okay, so from 2D we do all our measurements, and these days we use digital software. And so this is the natural head position. If you look at the chin, it's parallel to the floor. And we have a cephalostat here. Okay, so the natural head position is still not very well defined. It's an elusive position and varies from posture to posture. So we have difficulty in reproducing it. And usually with time, we want to know exactly what changes have happened, whether it's growth changes or treatment changes. And it's very important also in the body posture and alignment. We have a myocentric state where there's a delicate balance of all the muscles and the and the skeleton. Okay, so these are some of the postural disorder discrepancies that can happen. We can have growth disorders, craniofacial dysmorphogenesis, craniofacial pain, spinal cord injuries, obstructive sleep apnea, temporomandibular joint dysfunction, occlusal disharmony, and periodontal defects. Let me just show this slide quickly. This shows an example of a, and I got this over internet, so pardon me. It talks a little bit about the forward head posture. Okay, so that's like normal position where we are really in a very balanced position. And this would be a forward head posture, which is detrimental for the whole body. And so there are several different positions that have been defined. Okay. So we move to the other slide. Okay. How do I move? Okay, thanks. All right. So usually, if you have a good posture, there's about 12 pounds head weight. But with a bad posture, it puts a lot more force on the spine, and it gets worse as the posture gets worse. These are the conditions that can happen where you have a TMJ dysfunction, pain around the neck and shoulder, go all the way down in your body. It's a common thing that happens. Problems with snoring, not having a good posture can also lead to wearing down of the teeth. So the next point I want to make is the occlusal plane. That position is where the teeth come to make contact. It's the interface between the upper and lower teeth. It's called the maximum intercuspation position, and it's a very important position in dentistry. And it's used as a reference guide to study occlusion, and also it's in a dynamic state because you can make movements laterally, forward, and posteriorly. Okay, so why is the occlusal plane important? When we have a patient who has a skeletal deformity, we can plan to do a surgical treatment where the jaw would be, of course we put braces and the jaws would be moved. But when we move the jaws, we have to decide where is the jaw going to be in relation to the soft tissue and the rest of the skeleton. So if this is the occlusal plane, if it's put too low, it will show too much teeth. If it's put too high, it may not show teeth when the patient smiles. So deciding the occlusal plane is very crucial in a lot of our treatments. Okay. How do I get out of this? Just escape key?
Yeah. Oops.
Okay.
Double click. And then F5.
What number was it?
Escape.
Double click on the slide.
Sorry about that technical difficulty. Okay, so this is the occlusal plane, which is the interface between the upper and lower teeth. Why is this important? Because that's where actually the switching off mechanism lies. When we swallow, the teeth come and meet and let go. So there's a switching mechanism, and that keeps the muscles, the neck, and the nervous system working in a good order. Oh, what's happening here? Okay, and we went through all this. I'm sorry about this. Okay. Sorry. Am I going backwards?
Yeah. You can't use it this way.
So on a lateral X-ray, that's the occlusal plane where the teeth make contact. Okay, so we have an occlusal line and we have a range of occlusal movements when we look at the teeth. It's almost like an ellipsoid, the occlusal plane. And here's a CBCT 3D image where the occlusal plane lies in the contact of the posterior teeth. We have a technique or a tool where we can measure the pressures where the teeth make contact. So the red area shows where we have a lot more pressure. Okay. So why is the occlusal plane important? It's very important for us to establish occlusal plane for facial balance and for a good functional occlusion. Okay, and I will just show you a little bit of the movements that we can do in, and again, I got this from the internet. Pardon me. This shows the range of motions possible with the teeth. You have the opening, right lateral, exclusive movements. Those are exclusive movements. The maximum opening of the jaw, lower jaw. Okay, so during all this process, teeth are touching, some are balancing, some are used as actually putting pressure on the teeth. And if this system is not functioning well, then we have problems with our neuromuscular system. So defining this is very important in dentistry. As you can see, this is a 3D model. It's not of a true individual person, and we don't have that capability yet. And it's almost like an ellipsoid, semi-ellipsoid shaped, the occlusal plane. Okay. So we have different movements. Actually, this reflects the way the condyle moves in the TM joint. And those are forward positions and very posterior position, the back positions. Okay. Okay, and here we have a plane diagram which shows, it's the envelope of motion, which shows the total motion of the mandible in different positions. And we are mostly interested in the occlusal plane, which is the top part of the movement. Okay. Okay, so what are the factors that affect the occlusal plane? We have genetic disorders like Treacher-Collins syndrome. There are several syndromes, Robin syndrome. During the development, we have craniofacial morphogenesis, environmental effects like thumb sucking, nasal blockages, which leads to mouth breathing, and also as a dental intervention. So the advances in 3D diagnosis and treatment planning through CBCT have led us to actually develop a 3D model of the head and neck. So we actually can now make all these images. This shows a treatment of a skeletal deformity after surgery. Okay, so we can also superimpose and we can see the changes. This was a treatment of a obstructive sleep apnea where you see a very narrow pharynx and the jaw was brought forward and it increases the size. However, there's a disconnect with 3D photos and 3D CBCT and natural head position. Most of the x-rays are taken in just what is seen by the operator at that time, what's the best confident position, but we don't have a position that we can really reproduce. And recently there was an article in the Journal of Oral Maxillofacial Surgery in 2011, and they found a new method of recording. I copied this from the article. And what they're using is a three-dimensional sensor with jigs. That's how it looks. It has an occlusal jig. It has a sensor here, and that's a face bow. Just to cut the story short, they scan the face first. When you have severe skeletal deformities, your natural head position is very hard to determine because of the asymmetries. So they scan the face, and then later on they scan it with the jig and try to transfer this to the initial scan. And then they remove the jig. And they claim there is not so much error in it. But there's at least about 2-3 degrees error, which could translate to about at least a couple of millimeters. So what's the future? What's the new direction? We are looking to get eventually a 3D, with all the 3 tissues, virtual articulator. So the missing piece in the puzzle is how do we orientate the occlusal plane in natural head position, and ability to reproduce this position well over time, over years. And we would like to localize the occlusal plane in real time and determine the exact occlusal forces within the occlusal cloud, or the ellipsoid that I was talking about, showing you. And using that to generate an occlusal plane that we can use for guiding us to put the jaws together, and maybe using the CAD/CAM technology to develop wafers during surgery and treatments like that. Thank you very much. This is Saint Apollonia from Egypt, who was a victim of torture. She didn't want to change her faith. Thank you for your attention.